Welcome to Her Dignity Network's webinar on reducing maternal mortality while raising infant survival, a case study from Kenya. We're happy that you have joined us. My name is Jennifer McVeigh, and I'm the Event and Education Manager for the Center for Bioethics and Human Dignity, a bioethics research center at Trinity International University. I have with me Paige Cunningham, who is the Executive Director of the Center for Bioethics, and coming to us from Kenya, Dr. Mary Adam, who is a pediatrician working in medical education and public health based at AIC Kijabe Hospital in Kenya. Welcome to you both. Before we get started with the case study, I would like to give you, our listeners, a little information on the Center for Bioethics and Human Dignity and Her Dignity Network. As a bioethics research center, CBHD exists to explore the nexus of biomedicine, biotechnology, and our common humanity, seeking to bring clarity to the complex bioethical issues of our day. And this is one of the reasons we created Her Dignity Network, the center's initiative on global women's health. We noticed that energies in the church are appropriately being directed to issues of abortion and sex trafficking, but the broader needs of girls and women are often overlooked or neglected. As we talked with people, it became apparent that there was not one place where all of the various health issues that women and girls face around the world were being discussed. What is unique about this initiative is that it connects a global network of people and organizations who share two basic ideas. First, that women's dignity is ultimately about human dignity. And then second, that female bodies and health are essential aspects of both her dignity and our common humanity. Our vision is a world where the full dignity of girls and women, as equally made in the image of God, is reflected in their access to essential health care and appropriate biotechnologies, and their protection from medical discrimination and exploitation. And today is an exciting day for us because we are beginning our first campaign on maternal mortality and raising infant survival. And Paige, I'm going to turn things over to you and explain why we're focusing on maternal mortality and to get us underway with our interview with Mary.
Thank you, Jen, and I want to say hi to all of our participants. I had a chance to look at a few of the names, so I know there are a lot of friends out there. And just it means a lot to us that you're joining us today for our first venture in webinars and doing remote location from Kenya. So we're just praying that all the technology works. You will hear some silences from time to time because of the delay in hearing from Mary. Don't worry, we know it's there and we'll just wait and hang in there. Hopefully there won't be any glitches. And so to answer Jen's question, why did we pick maternal mortality and then the associated issue of increasing infant survival? And that's because this is one of those, what we might call like a mega issue or a meta issue, because it's not just about women's health, but the mom's health and her survival affects her children. It's very important to infant survival. It affects families and it affects communities. And Mary's going to dig into this with us this morning. It's also part of a global commitment to reducing maternal mortality as part of what's called MDG 2015, or the Millennium Development Goals. And I want to defer that for Mary to unpack, but we realize that this is something that has a fair amount of awareness now. But we are going to look at some of the less publicized aspects of maternal mortality and some of the positive measures that are being taken. We really wanted to get away from the politicized aspect of reducing maternal mortality that seems to always want to link it to abortion regulation in countries where that is simply culturally and religiously unacceptable. But we also wanted to focus on hope. And when interventions benefit a woman and her children, her family, and her community, that is what we want to encourage and foster and celebrate. So we're tackling a huge issue with a small lens focusing on Kenya. So enough of me. It's time to hear from Mary. So welcome, Mary. I'm so excited that you are there live in Kenya. And you have lived and worked there for about 3 years. What in the world led you and Rod to move to Kenya?
Well, Paige, thank you first of all for inviting me. It's a delight to join you in the Her Dignity Network. And the question about what led Rod and I to Kenya goes back a long time. When Rod and I were medical students, I was at the end of my 3rd year of medical school, and we went to work in Liberia in West Africa at a mission hospital. And I still remember the night when I was on call and we helped a woman whose labor was not progressing. And this is before ultrasound. And it turns out she wasn't able to deliver vaginally because she had twins. Only the twins were premature. And they needed oxygen to live, something that we didn't have available. And it was like that night I said to myself, I need to go back and see if I can do something to help women and their infants survive. So that's the story, Paige.
Wow, what a powerful introduction to your sort of second half life's work. And it's just amazing how it has really connected with what we're talking about today. And you and I have talked about the Millennium Development Goals when you've been here in our office. And I think now it's been updated to what they call MDG 2015 and beyond, so looking towards the next decade. So can you just kind of give us an overview of what's going on with maternal mortality worldwide? Give us some context, and then maybe you want to tell us a little bit about how Kenya fits into the overall picture of worldwide trends.
Great. Well, let's start with the world as we know it. Pictured this way, it's familiar and predictable. But if we imagine the world through a different lens, the lens of maternal mortality, it's radically changed. You can see that it's a massive problem. As recently as 2006, the risk of a woman dying as a result of pregnancy or childbirth during her lifetime was about 1 in 6 in the poorest parts of the world, compared with about 1 in 30,000 in places like Northern Europe. It's a real tragedy because no woman should die while giving life. Just some key facts: about 800 women die from preventable causes related to pregnancy and childbirth every day. Most of those occur in the developing country. And even within developing countries like the countries of sub-Saharan Africa, maternal mortality is higher in women living in rural areas or in poorer communities. Young adolescents faced higher risks, and skilled care before, during, and after childbirth can save the lives of many women. But there's a lot of positive because there's been a substantial improvement over the last years. It's just that we're not getting close to the level of decline we need to achieve our Millennium Development Goals. So let's take a look and see how it compares to what's happening with newborns. You see, again, this rather sad state of the world because the greatest burden of neonatal death remains in the area of the world where there just aren't enough trained health professionals to meet all the needs. Here's some key facts. Of the world's under 5 mortality, almost 40% of it is in infants and babies in their first 28 days of life. And in developing countries, and in Kenya in specific, more than half of all mothers don't receive skilled care at the time of delivery. And tragically, up to 2/3 of the deaths of newborns can be prevented. And while I said before that I believe no woman should die while giving life, I also believe that it is a tragedy to have so many infants die when 2/3 of these deaths are preventable. But back to maternal mortality, you can see here that hemorrhage and high blood pressure are big killers during pregnancy, but both of these causes are treatable. Timely treatment results in fewer deaths and better outcomes for moms and babies. So that's a summary, Paige. Back to you.
Wow, those statistics are kind of overwhelming. And I see that we have that big bulge in Kenya, both on that deep red bulge for maternal mortality as well as infant survival. And that's such a vivid picture of how they are interconnected. Tell me what you're seeing on the ground in Kenya. Does it match what this map is showing us? What's going on there?
Well, I'm sorry, you did see very clearly that Kenya features prominently and is a big red spot in that part of Africa. And in this case, that shows that we've got problems on the ground. And I think in Kenya, as well as other parts of Africa, there are some reasons that come to the forefront again and again about why women do not get the care they need. Poverty is an issue. Distance from a healthcare facility, lack of information, inadequate services are there, and also cultural practices. But Paige, there are things that can be done even in resource-poor areas. And it seems like these are things that the people in the Her Dignity Network might really be interested in. What do you think?
Yes, Mary, we want to know. And that's kind of the on-the-ground question. We see the data, we see all this information, but tell us what it actually looks like when you're working with moms and their babies.
Well, first of all, it's important for people to realize that there's a lot of different kinds of interventions that have demonstrated effectiveness to improve these horrible maternal and neonatal mortality statistics. The problem isn't that we don't know what to do at all, it's that we need to better understand how to do it, how to link people and better health practices in ways that work for them, that are a reality, something that can function in their real world. And you know what? This has to start at home, at the household level. This diagram illustrates this continuum of care. It's a continuum that needs to be strengthened if we're going to see the improvements that we want to see. And one of the main things that Kijabe's Maternal Newborn Community Health Project is doing is to help to build bridges between the household and the health facility. First, we have to start at home. Optimal nutrition and timely seeking of care has to start at the household level. Yet, if the community or a woman and her family have an inaccurate understanding about what's going to make her healthy or her baby healthy, if they have embedded cultural practices, she might make a judgment about what's in her or her baby's best interest that could be very different from what you or I might do. And that often includes not going to a health facility for delivery. So Paige, you can imagine there's lots of cultural and contextual issues that are part of the challenge.
And I know, Mary, thanks for that. I know that these vary from community to community, and even within a country there can be different health challenges in relating to people out of their culture and not trying to change their culture, but working within what's familiar to them. I know you've got lots of real stories about how this works. Can you maybe just share some examples of how to change maybe some of those practices in a way that makes sense for the women and their communities?
Let me tell you a few stories about what works, and if I talk too long, you'll just have to stop me, because it's exciting about the things that we've learned here in Kenya. One of the things that we've really learned, and in many ways it's pictured by this, what I'm trying to show here, of a picture of women and infants collected at one of the health facilities in Western Kenya. These mothers have walked a long distance and they've gathered here to get immunizations for their children. But most of these women would never deliver at the facility, a place where there's a trained nurse. And you have to say, why? Why would that be? But remember those issues we just discussed. Imagine this. Imagine if you had to walk more than 3 miles to get to care while in labor. Or if you weren't doing very well and someone had to push you in a wheelbarrow to get there. It makes getting to the facility difficult. What if you might have an option of paying for transportation, but your husband, who's in charge of all the money, doesn't think paying for transportation for you to deliver at a facility is a wise use of funds. Or imagine this, I mean, in some ways it's hard for us to get our heads around things that are as culturally connected, but if your mother and sisters all thought that only weak women delivered at a facility, what would you do? You'd probably deliver at home too. And so we really need to be working to change the stigma around so many of these health issues. And so we in the Newborn Community Health Project have been doing a variety of things. And just like the Her Dignity Network wants to focus on critical strategies that can improve the health, we want to share some of the things that we're doing. And we've been working training volunteers in their community to deliver health messages, that will increase the likelihood of success and delivery, that will help improve postpartum health and improve health for newborns in general. So let me take you to Kenya, all right? If you landed in Nairobi and drove about an hour and a half out of town, you'd come to a place that could look like this. Pictured here are a group of women. These women are all volunteers. They work as subsistence farmers, and they were trained by our Maternal Newborn Community Health Project. You see them here teaching at a public function, and they're teaching about the value of delivering at a health facility. Men and women are present, as are children. And what they're doing is they're championing, they are being leaders saying, we can change our behavior and this is why it's worth it. Because you know, what we're really looking for is healthy mothers and healthy babies. And we are frequently requested by groups of women to say, hey, can you come and train us? We're requested by chiefs in the area and other community leaders. Some come and request training because they had a bad experience and they don't want it to happen to someone else. Let me tell you the story of a woman who I'll call Shiru. Shiru knew her local community health volunteer, somebody the Kijabe Maternal Newborn Project had trained. And the volunteer had talked to her about danger signs in pregnancy. And she had come around just to visit with this mom and see how she was doing. And the mom told her, I don't feel well. And the community health volunteer noted that she had a fever and asked and found out that her membranes had already ruptured. The community health volunteer tried to convince the woman and her husband that she needed to go into a health center, that if you had your membranes rupture and you hadn't gone into labor, you needed antibiotics because infection could be a possibility that would hurt the mom or the baby. But the woman and her husband refused. The next day, this volunteer went again and tried to persuade them. Again, the family refused. Unfortunately, the mom went into labor, and unlike the beautiful infant you see pictured here, the child was born dead. The family was so sad. And they went after this happened and asked this volunteer if she and those who taught her would come to the funeral of the infant so that they could teach others, because they didn't want anyone else to have that horrible event of having their infant die happen to them. Here's one of our nurses, Priscilla. Priscilla, as you can see, is also using simple visual aids as part of her teaching. And Priscilla also had issues where she would work with community health volunteers and they would try and convince people that there are some danger signs in pregnancies that you shouldn't ignore. And rupture of membranes, if it's too early in the pregnancy, is something that can be treated medically to try and assist the mother not to go into premature labor, to give antibiotics to prevent infection. And if the baby is born really early, there are things that can be done to support that child. In this case, one of the community health volunteers knew of a woman in her neighborhood that had ruptured membranes, but knowing the danger signs, she called Priscilla. And she called our nurse and said, look, here's what's happening on the ground. I think I need some help. They talked together about ways they might consider persuading the mother that she needed to go in for care. And fortunately, in this case, the mother was persuaded. The mom came in and they sent her to Kijabe Hospital because of how premature it seemed that this baby was going to be. Fortunately, the antibiotics worked. The mother didn't deliver the baby for a few weeks, but the baby still came very early. However, the baby was able to breathe on its own, and we were able to help it gain weight by tube feeding it at the hospital till it had grown up enough. You know, we talked about teen pregnancy and how much of an issue that is. This young mother here was encouraged to deliver at the health facility by a family member, someone that looked to be about the age of her grandma. And the link that was made between the family member, okay, her grandma, and the facility was reinforced by these lay volunteers. In fact, a group of 6 women accompanied this young first-time mom to the facility and encouraged her to deliver there. And that kind of involvement and support can do so much to help bridge with the norms in the community that make it more acceptable for a woman to actually deliver where they can get the care they need. So, can I tell you more, Paige?
Yeah, I would love to hear some more stories. And as you do that, I have one question to help us focus on why this matters. Is we know that in terms of the overall challenge of the MDG goals, that's like hundreds of thousands of women. You're working with a much smaller number, and it's like, why bother? You know, this isn't a big sweeping program to change the whole country of Kenya. These are small projects, and you know, tell us from your perspective why that matters. And I think you can maybe do that in the stories that are coming. But I would just love to hear from you to encourage those of us back home or back in the U.S.
You know, it's a good question to ask because sometimes one thinks that really small programs may not have the level of impact that'll really save many, many lives. One of the things that's unique about the Kijabe Maternal Newborn Program is the way we're actually a pilot for all of Kenya's community health strategy. We're one of the sites where we're testing things on the ground that's being adopted nationwide in how to approach issues around developing community health volunteers and helping to train the people that are going to train community health volunteers across the country. Pictured here is Simon. Simon's one of our nurses. He's actually been part of the work group that's developing the community health volunteer training manual that has recently, in September, been published by the National Community Health Services Division of Kenya and is being spread out to every part of the country. And you can't be able to give input for stuff that's going to be a nationwide strategic rollout if you haven't done the kind of work on the ground that Simon has. Simon has had practice and understands what it's like to work at the community. Here you see him out in somebody's back farmyard with a whole women's group, okay? And you could tell they're having a good time. This is where we actually get to practice building some of the narrative kinds of bridges that need to go and be altered slightly into each of the different 47 different tribal groups in Kenya. You would think that there would be exclusive breastfeeding in places like this because people can't afford formula. But you know what? Exclusive breastfeeding is something we train on very, very strongly. In this particular part of Kenya, there's a lot of grandmothers who think you should be giving very young infants tea or sweet potatoes. And you have to build bridging stories to help people go from what their context says, what their grandmother and their mother and their sisters have all been taught, to something that's the better health practice, which is exclusive breastfeeding for 6 months. So here's the kind of story Simon tells. And this is the kind of thing that you can model in front of others, both those who are training community health volunteers across the country. Simon will point to a nearby group of goats, and he'll say, look at these goats over here. He said, now, if this mama goat fed her babies tea, would they be strong and healthy? And usually everybody laughs because they know the answer is no. If those newborn baby goats don't get their mother's milk until they're developmentally ready for solid food, which for a goat is grass, okay, they know that baby won't be strong. And those kinds of conceptual narrative bridges are essential for communities to get it in regard to the better health practice, to risk doing something that grandma's telling them not to do. In other areas of the country, for example, in the very dry desert region of Turkana, many women don't breastfeed exclusively for 6 months because they spend 4 or 5 hours a day walking to get water and carry it back. And they can't carry so much water and the infant, okay? So as a result, the babies are fed less often, reducing weight gain. And so in settings like that, you have to work actively with people in that community to build logistical strategies about how can we help this mom in terms of her culturally expected role in terms of water collection. Are there ways we can support each other? Are there ways we could organize to have cattle grazed nearer to a specific water source during the early months of a child's life? It requires a lot of different ways of thinking and communicating. You gotta practice what you're doing before you really want to roll it out nationwide. So Paige, is that helping give the flavor?
Absolutely, Mary. Hey, I want to ask you one of those questions that we learn from, and that is, what have you learned that does not work? I mean, you mentioned, for example, the grandmothers. Do grandmothers, once they see the results, accept this change in breastfeeding? Have you had some of those sort of disappointing situations that actually help the project be more effective?
We certainly have encountered some very disappointing things. Simon and I went to an area of Kenya in the western part of the country. And this is an area that the first missionaries arrived at in the early 1980s. And there were a wide range of cultural practices or rituals that surrounded the time of childbirth. And it became very clear to us that these rituals had deep-rooted spiritual dimensions. And for example, one of the rituals had to do with after delivery, the placenta needed to be buried in a place identified by the father, and that during this time where the ritual of the placenta being buried occurred, the baby was given a name. But you weren't supposed to feed the baby in this tribal group until after the baby was named and this ritual was done. And if you did, horrible things could happen to the baby. And so here was a case where deep-rooted cultural practices that had spiritual roots that were not Christian were something that make giving what you might think is a simple health message something that's almost impossible to do. What woman in her right mind would want to make a spirit angry if that was who would be in charge of whether her child would live or die? And that's just one of the examples in some of these more remote places where we're actually confronting more than just educational issues, but deep-rooted spiritual issues, Paige. And so, yes, we've had times and places where the message isn't received. And then again, whenever you get a new message, you have to remember that one time is not enough. Just because you say it and you're a nurse or a trained health professional doesn't mean people believe you. Most people believe people they trust. And that's one of the reasons we work with community volunteers. Because if you're a respected and trusted person in the community and you start leading the way and saying, I'm going to live different, and your life shows it, then you have a chance of actually engaging that local community in a change for positive health.
So Mary.
Yes, Paige, that's one example.
Yeah, I'd like to know about how do you find these community volunteers? They seem to be the key, which is kind of surprising. We would have expected it to be the healthcare professionals, but it seems like they can't do their work without the volunteers. How do you find volunteers to be trained?
Well, you've got to be deeply rooted and connected in these communities. And so you need to start with figuring out who the local leaders are. Every village has like a village mayor that's called a chief. Those people know who's respected. You need to go to community-based organizations. If it were in the US, you'd probably look for Girl Scout and Boy Scout leaders. You'd look for church leaders and say, could you give me the name of someone who's well thought of in this community, and let's invite them to see if they'd be interested in learning more about health from someone who's had the kind of training and experience. Usually that's someone who's had educational opportunities that haven't been an option for people in these communities. So we start there, Paige.
I love that whole approach. It seems like it's not efficient, and yet the way you described it makes complete sense that you work within the reality of the context that you have. And something you said earlier really just resonated with me and with the whole purpose behind Her Dignity Network. And if anybody's looked at our guiding principles, you will recognize that our first principle is that we're motivated by the love of Christ. And you talked about these spiritual realities of this village where the practice was, don't feed the baby until the baby's named, and how difficult that is. This is one important aspect of the network, which is not just giving good medical care, not just doing community education, but dealing with the spiritual realities that exist on the ground. Have you come across situations where you've either felt the support of people praying for you, or you felt that prayer made a difference in the project or in the situation?
Paige, it is absolutely essential to have the kind of prayer backing and support, because working in this context is hard. A lot of things don't work well in developing countries, whether that's the electricity, for which we are thanking God for the answer to prayer, that my electricity hasn't gone off, ceasing our communications during the last half hour, okay? To the fact that rain can make enough mud that you couldn't get a four-wheel drive through to some of these areas, and they might only be 5 miles from the main road. The other place we see the power of prayer and of a changed heart is, face it, if you were making $2 or $3 a day doing hand labor vegetable growing, how much would you feel like volunteering? To sustain the kinds of longer-term impact in the community, you got to have a love for the others around you. And only a heart changed by Christ's redemptive power gives you enough love to be unselfish enough to reach out and serve others. So those are just a few of the ways I could talk about answers to prayer.
Wow, I think that's really important for us to hear, and just the fact that you said that it's hard, and sometimes those of us in the West are so driven by results and numbers that we forget about people's lives and what a difference it makes in their life to have someone who is just there for the long term. And that's just, I think, an encouragement to us who can sort of get overwhelmed by the scope of the numbers and forget that there are actually people-to-people situations that are happening. I wanted to talk a little bit about some of the specifics of the Maternity and Newborn Community Health Project that we're featuring on the website. But before I do that, I just wanted to make sure that you've had a chance to kind of do the landscape there of anything else you wanted to any other issues you wanted to bring into this. And a second question is that we're really concerned and aware of the ways that women and girls are discriminated against in healthcare, that they're subject or vulnerable to medical discrimination and exploitation. Is that a factor in Kenya and any of the work that you do?
Well, let me answer one question at a time, which is one of those things is about the scope of our work. And pictured here, you see a whole bunch of moms and babies. And one of the things we do that helps increase the scope of our work is stuff that we do to train nurses and to train the person in the government healthcare system called a community health extension worker, because we're helping them to see that they can capitalize on every single opportunity to promote health for both mothers and their babies. Here you see a group of women, and one of the women is a nurse. She has a white top and a navy blue blouse skirt on. And also part of this picture is one of the people that we helped this nurse coach to be a community health volunteer. And we do coaching and helping them learn how to work with lower literacy populations, for example, because nurses in general have had a lot of educational advantages, but they haven't been trained on working with lower literacy populations or necessarily volunteers. The nurse pictured here's really found an outstandingly talented volunteer, and that volunteer in the community is part of the reason why all these women are coming. And they have some important stuff on their agenda, like weighing babies and getting them immunized and sharing health messages broadly for any woman or man who would gather. And so our project is really all about delivering evidence-based behavior strategies to different families and building bridges between that household, opening the door literally and figuratively for better health care. And Paige, the second question you asked about women being discriminated against in terms of health care. In Kenya, the discrimination is not necessarily that they don't have any access to a facility, but it's these other kinds of things where if your husband, head of household, doesn't see it as a high priority, taking the money to get transport there means that instead of being able to take, get on the back of someone's motorcycle and spending what would be 50 cents to you and I, they have to walk. And that kind of discouragement for getting health care is pervasive. The government of Kenya is also struggling to get more health facilities closer to where people live. Their goal is to have every person in Kenya be within 5 kilometers of an actual health facility, I can only say that they have a huge way to go. And that's a disincentive when it's hard to get there. So, on one hand, women aren't discriminated more against than men in regard to healthcare access, because if you gotta walk far to get to the facility, you gotta walk far whether you're a man or a woman. But there are ways in which they are discriminated against. And in general, women do not have the same level of voice or options or rights as men, and that's very cultural. The common saying here goes that women do labor, meaning manual labor, and men make decisions. And so they are lower in the decision-making hierarchy, which is always a disadvantage. But even in spite of that disadvantage, Paige, women like the one pictured here, they and their families want information. Even if it's information they're not necessarily quite ready to use, they definitely want to make the world a safer place for their babies and themselves. And Paige, isn't that part of what the Her Dignity Network is all about, making the world a safer place for women and their babies?
Absolutely. I mean, I couldn't have said it better. So I love the way you talked about how it is for women in that context. We tend to kind of generalize about other cultures that we don't know because we don't live there, and just, you know, the not having the same voice or the same decision making doesn't mean that the same thing for each culture and what's going on. I remember you said earlier in one of those community health training sessions that there were men present, and so it sounds to me like you're including the men in these outreaches, which sounds like it's really benefiting the whole community. I want to talk about the specifics of your project, and so maybe my last question to you is, are there other benefits to the community beyond the health of the mother and the baby?
Yes, Paige, there's a variety of benefits that come to the community through this. One of the things that gets addressed as you grow in the training and become able to understand the things that are accurate health messages is these women have to, and men who are trained as volunteers, have to grow in public speaking. They have to grow in forming different kinds of social networks. They have to grow in problem solving. And one of the fascinating ways they start to grow is they start to grow in understanding that even though their community is poor, their community has strengths and assets that they maybe hadn't been aware of. And the ability to bring people together to solve problems is a huge residual benefit that comes from this training that's not directly health related. So that's just one of the very tangible ways that we're seeing benefits come as a result of this training.
I love the way that is so multidimensional, and the way that God works through you and the people who are working in these communities. But I want to explain how this project works through the website. One of the things that's really important to us in the network is that we point to work that is being done that is consistent with our guiding principles. And we know that not all these principles are shared by people who are active in women and girls' health, because we guard their dignity from the time of conception through death, and we don't make exceptions for girls in the womb, and so we do not support abortion rights, which is on the agenda of some other organizations. And so we're very careful about the projects that we actually feature on the website, that we want you to be able to trust them, that if you feel led to support them financially, to pray for them, that they are projects that are operated with integrity. And I'm going to tell you about this first one. It will be linked. It's linked on the website as a featured project on our maternal mortality topics page, and you can go to that and click through to support the project through Equipping Africa. And any gift will go directly to the project. The network does not take any funds from that. That's just to point you towards that project if you want to get involved in supporting or praying for what Mary and the Community Health Project is doing on the ground. If you want to support the network itself so that we can continue to do this work, then you can do that on the website, on the Get Involved page. So there are two ways that you can get involved. But we want you, as you are maybe sharing this with your friends, to just be aware of the kind of, I hate to say screening, but the kind of trust that we have for Mary and the project that she is involved with, and so that you can give with confidence that your gifts will be well managed and handled with integrity. And so Mary, just give us like 1 minute on the project as you wrap up here, and then we'll take any questions, and those that need to leave and don't have questions, we'll be able to say goodbye to them. But we just want to make sure that you get the last word on that, and then I have a question for you.
Okay, well, pictured here you see some of the graduates from our training program, and we choose to honor those who have completed the training, who are moving to become volunteers, with both t-shirts and a certificate. And training these people is an investment. It's an investment in health and hope. It's an investment that empowers women and men and their families. And so for those who are interested and want to join us, we'd be thrilled. As you can tell, we are supportive of the goals and objectives of the Her Dignity Network, the valuing of women from conception through natural death. And it makes a difference. So if you're looking for ways that you can pray for us, we'd appreciate it. If you would like to champion our cause, we would be thrilled. But pray for open hearts and minds to the messages, both the messages of health and the messages of hope and the gospel. Pray for us to have courage as we face many different challenges. One of which is if the lady holding the baby, who's our community health worker volunteer, hadn't convinced this mom to deliver at a facility, probably both this mom and baby would be dead. And yet here they are. And it's such a joy to be able to work with people in the communities, and Paige, to be able to work with people like you and your team at the Center for Bioethics and Human Dignity. So thanks for letting us have this opportunity, and I'd be delighted to answer any questions I'm able.
Thank you, Mary, and I hope that those of you who've joined us will stay, because I know we have a couple of interesting questions coming up here. But I did want to show you I think we have some slides on the links for the web page to move forward. While we're doing that, here's the question from one of our participants. Is there a focus on first-time mothers?
In terms of the training, there is always a focus on mothers. But in Kenya, if you're going to deliver at a facility, you're far more likely to do it with the first baby. And so part of what we're trying to do as we're working to train our volunteers is to encourage moms not just to come in the first time, but to come in every time. And then to do follow-up visits at home in the day or two after delivery. Because one of the things we're seeing from our research is that a substantial number of the babies are dying, whether they deliver at a facility or they deliver at home, in that first 7 days. So that means there's problems with breastfeeding, there's danger signs that aren't identified. And so while we are trying to focus on first-time moms, the understanding of danger signs doesn't improve enough. So we're really aiming at getting every pregnancy to deliver at the facility, and then doing follow-up at home in those first early days to see how things are actually working when mom is home with baby, to see if we can pick up stuff that might be preventable.
Thank you for that answer. Here's another question. Are there specific agricultural projects to improve prenatal nutrition? What a great question.
In Kenya, there are a variety of nutritional projects. One of the biggest things is that some agricultural practices that are very accessible to people in the agrarian parts of Kenya can be done. And some of that is just like planting seeds all at the same depth. So when a corn plant grows up, all the leaves of each plant in the row get equal access to the sun. And so our nurses who are part of the maternal newborn community health team have actually had some agricultural training from a group called Care of Creation so that we can be able to share those practices. And when we see areas that we are in that are open to that, we're able to refer them for more extensive agricultural training. In the pastoralist communities where they're mostly doing herding of goats and cows, there are different sets of issues. And there we're working on nutritional things like when a cow gets butchered, we want to try and make sure that most of the liver of the cow actually goes to feed pregnant women so that they have that increased iron source. And that requires, believe it or not, seriously working and networking with men, because the organ meat's normally something given to men.
That's just such a fascinating aspect of working within the community and drawing from the community what they have. So thank you for that answer. Here's another question. Do you encounter many special needs or premature infants in your practice? And if so, what are the challenges that you have in dealing with that population?
We really see a huge amount of special needs children, particularly hydrocephalus or water on the brain. And the defect that usually causes that is a spinal defect that fits under the category of meningomyelocele. We at Kijabe Hospital are probably the best center in the country for children with these kinds of neurosurgical problems. And so it's not uncommon during the time where I'm functioning as a in the hospital pediatrician that we'll see and care for those children. In fact, one of the guys who wrote the major textbook on pediatric neurosurgery has given the last part of his career to Kijabe Hospital, where he's taking care of these very vulnerable children and training up a generation of Kenyan neurosurgeons to carry on after him. But that means that you need a community volunteer who says there's something that can be done. Because if your best knowledge is that there's nothing you could do to help this child, you wouldn't go seeking care. And often we'll have our community health volunteers identify some child who is has deformities, even simple deformities like cleft palate, cleft lip, club foot. And if they are able, they just share that with one of our team nurses, and we can help them get referred to a place where there's the possibility of getting care. So you can see how links within that community to any facility, to a high-level facility that does surgical care for, neurologic issues in children. You need that linking person, and that link, the first link, is the community health volunteer.
Well, Mary, it's just so encouraging to hear about this truly holistic, comprehensive vision that you have. And then I'm going to ask the final question
Yes.
as we wrap up in our last couple of minutes, and that is, what are the attitudes within the community toward children with disabilities?
You know, children with disabilities are often seen as a curse, and women are frequently blamed that they did something wrong, and that's why the child came out this way. It's never the man's fault, and it's just tragic. Even when these parents do their very best, you can imagine that if you had a developmentally delayed child or someone who was retarded, and you had to go out in the field and plant and harvest, or no one would eat, we'll find these children sometimes tied inside their home. And they're tied there not because they are not, they're hated, they're tied there sometimes for their own safety, because if they wander off, there will be no one to care for them. We also get so many children at Kijabe Hospital who have developmental problems, especially these neurologic problems, where a child was abandoned. And someone knows that if they can get that baby to Kijabe Hospital, there'll be help for it. So having a deformed child in any way is a very tragic thing for the family, and having a place like Kijabe that's willing to help even these most vulnerable children is really one of the ways we're trying to share God's care and love for the least of these.
Mary, thank you so much for just giving us a window into Kenya and the lives of women and children and their families and their communities. It's really given me a lot of new insights, so thanks for sharing some things that I just had no idea about. I wanted to let our participants know that this webinar will be available on the website in the coming weeks. It'll be featured on the homepage as one of those featured resources, and eventually will also be on our topics pages. We have resources that have been uploaded in the area of both maternal mortality and neonatal deaths or infant survival. The website is a place where we collect resources that are based on empirical research, as well as United Nations reports, news links, all kinds of information on a variety of ways of understanding these different issues. And those resources are just going to continue to grow and grow in the weeks and months ahead. So those are available for you as well. So I want to thank all of you for taking this time to be with us. Stay tuned to the website to find announcements about our next webinar. And we also would just welcome your feedback if you wanted to give us feedback on the HDN page. Hope you all have a wonderful afternoon, and thanks again for joining our webinar.